Thank you all for joining. This session will cover the test case on developing objective performance criteria for outcomes after hip and knee replacements. My name is Duray Kim. I am a project manager here at NEST, and I will be moderating this session. We will be joined by William Jung, Acting Director in the Division of Joint Arthroplasty Devices at the Center for Devices and Radiological Health at the FDA. Liz Paxton, Director of Surgical Outcomes and Analysis at Kaiser Permanente's National Implant Registries Program. She is also the co-lead of MD EpiNet's Orthopedic Coordinated Registry Network. Art Sadrakian, who is a professor of population health sciences at Weill Cornell Medicine and is the director for both the Institute for Health Technologies and Interventions at Weill Cornell Medicine and MD EpiNet. He's also a NESTcc governing committee member. And lastly, Paul Borhorst, who is the Vice President of Worldwide Clinical Research at the Pew Synthesis, which is a part of J&J. This is just a quick snapshot of the test case. The aim of the project was to develop an OPC for major outcomes following implantable device use in primary hip and knee replacements. Major outcomes include all-cause and cause-specific revisions and the reoperations at 2 years following primary hip and knee replacements by utilizing literature review, registries, and claims data within the OrthoCRN network. This test case was thought to provide important evidence of long-term device outcomes, which align with our goal of understanding the feasibility of integrating real-world evidence and regulatory decision across the device ecosystem. This test case also aligned with the strategic priority of NEST to enhance the use of real-world evidence to address the lack of high-quality, timely, and cost-effective evidence. In this study, an OPC developed can support informed decision-making for various stakeholders. Our role here in this test case were to enable in this industry stakeholder participation in the design and conduct of the study, and also to facilitate collaboration with FDA to provide insights in study design and analysis and reporting, including regulatory implications of the project objectives. Just as a reminder, if you have any questions throughout the presentation, please do type them out in the Q&A box below, as we'll have a question and answer session at the conclusion of the session. And with that, I will hand it over to Paul.
Thank you very much. I'd like to, first of all, thank the organizers of this session. And I would also like to thank multiple J&J colleagues that helped me with this. I've been with J&J all in the orthopedic space for the past 30 years, and I'm currently serving as the Vice President of Clinical Research for the Pew Synthesis. So I am an employee of Johnson & Johnson, and these views are mine. They're not of the views of Johnson & Johnson or of the overall medical device industry. So I think just in terms of looking at the background, obviously primary total hip replacement and total knee replacement have been very well documented, very, very successful procedures, and they're done in high volumes globally. There's numerous high quality national joint replacement registries that have decades of data available for researchers that are aiding in the establishment of OPCs for pivotal pre-market investigations. And I think that, this is an area that's just ripe for OPCs because doing randomized controlled trials in surgical treatments can be very, very difficult for numerous reasons that have been well published in the literature. Adoption of pre-market OPC designs could improve the timely access to innovative devices. So some things that need to be considered for OPCs. So obviously, OPCs must come from a very solid scientific evidence basis. They have to have a well-defined patient population that aligns well with the source of the OPC. And if not, then there need to be adjustments made for differences. The endpoints that are chosen should be clinically meaningful, they should be objective, and they should be commonly used. I think they also should consider composite endpoints, especially if they can be inclusive of both clinical, imaging, and most importantly, safety endpoints. The quality of the protocol, the quality of the study conduct, and the analysis and reporting are critical. And I think that the transparency of the OPC and the development and use for multiple stakeholders would aid in this adoption. So I'm really excited about having a multi-stakeholder panel and group that's working on this. The other thing that I think is really important is that this shouldn't be just a snapshot. It should be an OPC that can be updated over time. It should be an iterative process because things do change over time. So we need to continue to improve patient care. And I think OPCs are one way of doing that. So thank you very much. I appreciate again the opportunity to be with you today. And I'm going to pass it over to Dr. Sadrakian.
Thank you very much, Paul. It's a pleasure to be here today and share really robust and extensive amount of work that our team, MD Epinet Orthopedic CRN, has performed and conducted over the course of past 12 months. And I'll be presenting our achievements with my colleague, Elizabeth Paxton from Kaiser Permanente. I want to acknowledge and thank our team from Weill Cornell Medicine, from Force TJR, from Kaiser, of course, from J&J collaborator Paul Wurhorst, and our partners from FDA, with the leadership of Raquel Pitt, who is the head of the center dealing with orthopedic devices. So OPCs, or objective performance criteria, or objective performance goals, called OPGs, typically refer to a numerical target value derived from historical data from clinical studies, registries, or any other meaningful and reasonable data source, and may be used in dichotomous manner for review of the comparison safety and effectiveness endpoints. This is from the guidance, FDA guidance of pivotal studies for devices. Now, when we typically like objective performance criteria used when technology is relatively mature, which is the case for orthopedics in here, and there's substantial amount of evidence. Objective performance goals overall can be developed when technology is less mature and evidence is less robust. In the past, OPC methodology has been used to evaluate clinical performance of prosthetic valves, urological devices, and FDA has experience of using this methodology for evaluation of the device submissions at the pre-market, and also evaluation of devices at the in a post-marketing setting. We think that since the launch of real-world evidence guidance, FDA is encouraging use of objective performance criteria as one of the tools possibly that can be used for a 510(k) program as well. So what are the requirements for developing OPCs? You know, we approach from the development leveraging real-world evidence. And the reason for that is that it's difficult these days to do clinical trials with thousands and thousands of new technologies available in orthopedics. They're expensive. There are problems with the enrollment and generalizability. Very difficult to do blinding, which is very important in properly designed randomized clinical investigations. More important, is very hard to conceal the allocation, which makes the clinical trials not very good tools often for evaluation of the technology, such as joint replacement devices. On the other hand, if we continuously synthesize the evidence and use real-world data, robust real-world data from registries, from claims, and from published literature, from clinical investigations, prospective cohort studies, we can develop those dynamic objective performance criteria, OPGs, as well. So the value is of course, when you have when you're able to develop a specific outcome metric for these established technologies, then the innovators can leverage single-arm clinical studies and hence reduce the burden on investigators, but still keep very robust methodology and robust design for analytic purposes. It can be used for total product lifecycle applications because it can be used from in both for pre-market and post-market settings. And I think there's growing experience of using these data for supporting labeling change decisions now. The UK National Institute of Clinical Excellence came up with recommendation almost 20 years ago when they issued a guidance that revision surgery after hip and knee replacements should occur about 5% at 10 years. So in other words, no more than 5% of the implants need to be revised at 10-year follow-up. So this is sort of an example of a benchmark that also internationally clinicians have been using and regulators have been promoting for evaluation of real-world performance. So in approaching robust OPC development using OrthoCRN network, we had two goals. First, to develop performance criteria for all cause and cause-specific revisions following 2 years after primary hip and knee replacements. And we used the data from Kaiser Permanente and Force TJR registry. We used claims data from state of New York and California. And we conducted systematic analysis of the literature, extracting data from studies conducted in the United States going back 10 years. Second goal was to use and develop objective performance criteria for patient-reported outcome measures at 2 years using Force TJR registry again, and also literature data. So again, this depicting the safety endpoints, which is 2-year all-cause and septic revision or revision for infections, and effectiveness endpoints, which is patient-reported outcomes. For safety endpoints of revision, data from Kaiser Permanente, Force TJR, claims data and literature, and the outcome metrics that we evaluated in terms of effectiveness include hip disability and osteoarthritis endpoints, HOOS, Harris hip score, which is more about clinical evaluation of hip functioning, and for in similar metrics for knee replacement, including KOOS measures, Knee Society score, and Oxford knee score. Finally, general health related quality of life metrics included EQ5D, Euroqual, short form 12, and SF36, which is SF questionnaire, again, that has 36 components in PRO measurements. A most important step here to highlight that at the end, after extracting all relevant literature and data, we combine the evidence with the cross-design synthesis for developing the summary measures that are likely to be more robust as OPCs. So now we'll talk about objective performance criteria development related to all-cause revision and patient-reported outcome metrics following 2 years after hip and knee replacements. My colleague, Elizabeth Paxton, will cover registry evaluations for both safety and effectiveness.
Thank you, Art. So as Art mentioned, I will be presenting the Kaiser Permanente revision results, as well as the patient-reported outcome measure results from the Force TJR registry, and then also summarizing some of our claims findings, followed by Art presenting the literature and the synthesis of this body of work. So in looking at the total joint registry results for Kaiser Permanente, we looked at all-cause revision as well as septic revision, but we'll focus on the all-cause revision today. We applied Kaplan-Meier survival statistics with 95% confidence intervals for 5 different subgroups, which consisted of conventional total hip replacement, hip resurfacing, posterior stabilized total knees, cruciate retaining, and unicompartmental knees. We also stratified the data by age and gender. So our inclusion and exclusion criteria, we focused on, for total hips, we focused on primary total hips with osteoarthritis as the diagnosis. We excluded metal and metal with a large head size. That resulted in conventional hip replacement, 92,173 cases. We also had 1,242 hip resurfacing within our study. For primary knees, we also focused on osteoarthritis as the primary diagnosis and excluded hinged and fully stabilized knees. This resulted in over 5,000 unicompartmental knees, almost 200,000 conventional total knees. And that was broken up into posterior stabilized, which were the majority, 120,000 of those, and cruciate retaining, which was over 53,000. So these are the results broken down by the different classifications. For a total hip replacement, for all of the patients, the overall revision rate was 2.1%. We also looked at gender and age. Females had a slightly higher rate of revision, and that was predominant in the younger age group. In terms of hip resurfacing, we had a 0.5% 2-year revision rate. And as you can see from this table, females had a much higher rate of revision than males. In looking at total knee replacement, the overall 2-year revision rate was 1.7%. The revision rate was higher in males as well as younger patients. Unicompartmental knees had a slightly lower revision rate of 1%. And we also observed the higher rate of revision in younger and the male population. In looking at cruciate retaining and posterior stabilized knees, the 2-year revision rates were 1.6 for cruciate retaining and slightly higher for posterior stabilized at 1.8%. And again, we see a higher, slightly higher revision rate for the males and the younger patients. So next, we're moving on to the patient-reported outcomes. So in looking at outcomes, we evaluated both global and joint-specific health. And we're able to evaluate these components using the Forced Total Joint Registry, which consists of a prospective cohort of nationally represented patients from 28 states. We evaluated the SF-36 mental composite score, as well as the physical composite score. In terms of joint specific, we looked at the KOOS for knees, KOOS for hips, and also the KOOS and KOOS Junior. So in looking at this patient population, we had almost 4,000 patients with baseline data as well as 2-year follow-up. And in looking at the 2-year change, there was a slight increase for hips in the mental composite score for the SF-36, a stronger increase in physical composite score. And then when we look at the KOOS score overall, we had a mean change score of 45, indicating improvement. And we saw that across the board in pain, activities of daily living, and quality of life, with quality of life having the largest increase and improvement. We also saw improvement in looking at the HOOS Junior as well. In evaluating total knees, we see similar results with the mental component score, slight increase, a stronger increase in terms of change with the physical component score. The knees, we did see an overall KOOS score increase, not as much increase as the hips, but we do see the same pattern with pain, activities of daily living, and quality of life increasing. And this is also mirrored in the KOOS Junior score. So next, moving on to the claims data, we have 2-year revision results. The claims analysis focused on New York State data from January 2016 to December 2018, and California State data from October 2015 to 2017. And we focused on those years primarily to capture ICD-10 coding, which would allow assessment of laterality. The primary endpoints consisted of all-cause revision and septic revision. Similar to the revision analysis that we conducted for the registry data, we examined 2-year Kaplan-Meier analysis with 95% confidence intervals and stratified by age and gender. So in evaluating the total hip arthroplasty, we focused on patients who had a primary diagnosis of OA. We also focused on that same patient population for knees. For hips, we had over 70,000 patients from the New York claims data and 67,717 from the California claims data. For knees, we had over 100,000 from New York and 116,559 from California. For the claims 2-year revision rate, you can see the overall hip revision rate for 2 years was 2% for New York and 2.6% for California, and combined 2.3%. The females had a higher rate of revision in the combined and the New York and California data sets. And that was more pronounced in the younger patients. For knees, you can see for New York and California, again, slightly higher in California, 2.1% and 1.8% in New York, and combined of 1.9%. We see a similar trend as we saw in the registry data with younger males having a higher revision rate. So next, I'll pass it off to Art to summarize the literature data analysis.
Thank you very much, Liz. That was very comprehensive. So we evaluated and searched systematically all studies, relevant studies of osteoarthritis patients. Our first criterion was that 90% of the cohort should include osteoarthritis patients. And second is that really smaller studies would not have enough power to evaluate endpoints of interest. So for evaluation of patient-reported outcomes, a criterion of at least 100 patients was chosen. And for evaluation of revision outcomes of at least 250 patients enrolled was the criterion for inclusion. And we went back 10 years to look at the published literature. Next. So after doing this review, interestingly, and systematically looking at the quality of publications and relevance, we had 8 studies that in a total hip arthroplasty context that evaluated SF12 and SF36, EuroQol 5, including visual analog scale, Harris-Hip score, and Hoos questionnaire. We had only 2 studies that were related to resurfacing surgery. We had 24 studies evaluating patient-reported outcomes and functioning after knee replacement. And again, they included SF12, SF36, EuroQoL 5D with visual analog scale, Knee Society score, Hoos questionnaire, and Oxford knee score. Finally, only 7 studies evaluated unicompartmental knee arthroplasty with the endpoints of SF12, EQ5D, Knee Society score, and Hoos. So to do evidence synthesis of literature and evidence from registries and claims, we chose robust methodology of random effect meta-analysis. This method is quite robust to address the issues of heterogeneity. We also did some sensitivity analysis that confirmed robustness of our results. Look at heterogeneity again. We'll repeat all the models by stratifying by type of study design, whether it's registry, claims, or literature. For evaluation of the total hip and knees, we'll look at the effect of censoring. For example, if more than 5% of patients were lost to follow-up versus less than 5% of patients were lost to follow-up. We did leave out analysis of removing single study to see if any particular study had a really large effect on estimate. Look at the publication bias and use the R package of metaphor for meta-analysis. I'm just going to show only one example of this kind of evidence synthesis, meta-analysis, stratified by source of the data with literature versus claims and registry data that we had direct access in terms of analytics that Liz covered before. But you could see remarkable consistency of evidence from the literature and also our findings from claims and registries shows robustness of our findings and association. In this case, 2-year revision rate for after total knee replacement being about 1.7% at 2 years, and with confidence intervals from 1.4% to 2.0%. As an example, summary table that you can find in our report when it's available, a variety of these numeric values that we proposed based on analysis of all data and aggregated analysis with meta-analysis, combined analysis, pooling, pooled analysis of the results. Similarly, for effectiveness, we focused on patient-reported outcomes and functioning scores at 2-year follow-up. We felt like the 2-year endpoint results are the most robust for evaluation and less likely to vary. And this can be, change scores also can be considered, but at this time we believe that 2-year outcome scores are more likely to be robust. So in summary, we created robust and dynamic OPCs. We have now a methodology to update this as new evidence is generated or becomes available. We can continuously look at the information. It's really important when applying the results and implementing OPCs that a cohort that innovators or manufacturers are using will have similar demographics compared to the population, the real world population that we used for development of OPCs. So we do have supplemental information for the stakeholders interested in using OPC, and they can have access to our demographics tables. It's really important to propose a non-inferiority margins when using the metric that we proposed. For example, in a case that I presented earlier, UK National Institute of Clinical Excellence proposed 10-year reoperation or revision benchmark of 5%. And if we apply the 20% relative non-inferiority margin that International Orthopedic Community, International Society of Arthroplasty Registries proposed, then this 20% relative increase would mean absolute increase of 1%, hence a non-inferiority margin at 1%, which one could use as a cutoff for OPC at 6%. So these non-inferiority margins are important overall because of the variation that is still possible in using cohorts, single arm cohorts. I think the use of OPC can help us advance safety and effectiveness of implants throughout this product life cycle approach. And we believe that collaborating with FDA helped us to advance these fields similar to what we hope the experience from cardiovascular and urology device settings can help us advance the regulatory and stakeholder overall decision making in air orthopedic devices. I'd like to pass it on to Will Jung to discuss these results from FDA perspective.
Thank you, Art. My name is William Jung. I'm the director for the Division of Joint Arthroplasty Devices in the Office of Health Technology 6, Office of Orthopedic Devices. Next slide, please. CDRH's mission directly impacts the public health in terms of protecting and promoting public health. In promoting public health, CDRH's rigorous review of pre-market submissions ensure that patients and providers have timely and continued access to safe, effective, and high-quality medical devices. CDRH's effort to also ensures patients and providers with understandable and accessible science-based information that we regulate. And CDRH facilitates advancement in medical device regulation by providing industry with predictable, consistent, transparent, and efficient regulatory pathways. This is vital to assuring consumer and user confidence in medical devices marketed in the US. The following are the device classification and regulatory pathways to market, which is based on risk assessment. Class 1 devices pose minimal potential for harm and regulated under general controls and exempt for 510K. These examples include syringes and hospital beds. Class 2 devices pose higher risk than Class 1 devices and regulated under general and special controls. Some devices may be exempt from 510K, but most devices in this class receive 510K clearance prior to marketing devices. These examples include total knee replacement or TKR devices. Class 3 devices sustain or support life are implanted or present unreasonable risk of illness or injury. General and special controls are not sufficient to support reasonable assurance of safety and effectiveness. Devices in this class requires PMA or HDE prior to marketing. Most of total joint replacement devices are regulated as Class 2 under 510K review process. A typical 510K cleared by FDA demonstrates substantial equivalence to a legally marketed device called a predicate device. The intended use and technology are similar to a device which is already classified. Clinical data is usually not required, but may be necessary for select submission. De novo pathway may be used to classify novel medical devices for which general controls alone or general and special controls provide reasonable assurance of safety and effectiveness for the intended use, but for which there is no legally marketed predicate device. Under de novo pathway, the novel device is determined to be low to moderate risk device. The term necessary in the least burdensome provision means the minimum required information that would support a determination of substantial equivalence or a reasonable assurance of device safety and effectiveness. The least burdensome provisions do not change the standard for pre-market approval or substantial equivalence. When considering the real-world evidence, FDA would assess based on the subject device's technological characteristics, such as modifications from previously cleared device, new device based on a substantially the same device design as a predicate device, non-clinical data, intended use, and labeling, such as clinical performance claims. Appropriate use of relevant real-world evidence would be consistent with least burdensome provision while maintaining standards for determining substantial equivalence. This concludes the presentation portion, and now we will enter into Q&A session. Please use the Q&A icon at the bottom of the screen or window to enter your questions. Thank you.